Good afternoon, Dr. Gardner. How are you?
I'm doing well. How are you?
Good, good. Thanks again for taking the time to join us on the Beating Melanoma project. And again, I just want to give you a brief introduction, and then we can get this really exciting session going. So Dr. Jerad Gardner is a dermatopathologist and the section head of the bone and soft tissue pathology at the Geisinger Medical Center in Pennsylvania. He has almost 130 peer-reviewed publication as well as multiple books, chapter published. He's author of the book Survival Guide for Dermatopathology and co-author of the book for Survival Guide for Soft Tissue Pathology. And one of the greatest thing about Dr. Gardner, I'm going to call you Jerad, is that you are so good as a teacher. And I first came across some of your work was actually looking at YouTube, and you have this amazing videos teaching dermatology residents about dermatopathology. So I thought, who will be a really good person to educate the public about what melanoma looks like, what normal skin look like, and what some of the atypical moles look like, and to get your insight on the pathology aspect of melanoma. So welcome.
Thank you.
All right. So one of the things that patients sometimes perhaps don't understand is they think that, a melanoma diagnosis can be as black and white. And, when a dermatologist do a biopsy, the tissue gets dropped into the bottle, and a week later, the patient gets a call. They say it's a melanoma. It's not a melanoma, right? And I think in reality, it's much more complicated than that. And I see you nodding. Why is that? Can you tell us, what should a layperson, what do they need to know? Why is it's not a binary black and white event?
Sure. I think the first complication about it that many members of the public don't understand, and honestly, many people in the medical field don't fully understand, is what happens inside the pathology laboratory. So pathologists are doctors who look at tissue samples and other types of samples and examine them either microscopically, like in my case, or with other types of instruments in different parts of pathology. And we are the doctors who run the laboratory. And so, you may think like a blood sample, you take some blood and put in a machine, and the machine gives you all the numbers of what your values are, your cholesterol or whatever, right? Even that is a little bit more complicated because a lot of people have to make sure the machines are running the right way. But when we look at tissue samples, like a biopsy, like your dermatologist would take, it's not done that way. We don't just plop the tissue into a machine and the machine spits out an answer, melanoma, malignant, or benign mole. It's not like that at all. In fact, we have a whole team of people that go through different steps of taking that tissue and converting it into a little glass slide with a thin slice of tissue that's colored a certain way that allows me or other pathologists to look at it under the microscope and figure out what cells are there and if they're normal cells or not normal cells. And we do that looking with a microscope, just like this one right here, a light microscope, and looking at tissue slices under the microscope is kind of the same way it's been done for maybe over 100 years. Obviously, we've improved some parts of it, but that part of it takes a lot of manual steps. And that's part of what takes some time to have it done, is that the tissue has to get soaked in that little solution of formaldehyde or formalin. And then we have to cut it and measure it. And then we soak it in a series of different chemicals and embed it in a little block of wax. And then some very skilled techs in the lab called histotechnologists, they take that embedded piece of wax, they're the ones who do the embedding, and then they put it on a machine with a little razor blade that slices a 4 micrometer slice, 4 microns, like a little salami slice, only way thinner than paper. And they float that on a bath, scoop it up on the slide, and then they dip it into the different dyes and chemicals that give it the color that let me see it. And then I have to interpret it based on all of the training I've done of looking at normal tissue and abnormal tissue. And I have to figure out, is this normal or not? And if it's not normal, what's wrong with it? And if it's bad, if it's malignant, if it's melanoma or a nevus. So that's the biggest thing, is all those steps take a lot of work and time. And there's some degree of subjectivity in the process. Most of the time we can look at a slide and really quickly decide this is cancer or not cancer. But sometimes there's a gray zone in the middle where we're not sure and we have to do extra steps to work it up. And we'll probably talk about some of that in a minute. But there's a lot of different steps that go into it and require a lot of people that have a lot of training to make it all work the right way.
No, I
So
love
that's what's happening behind the scenes in the lab. It is a bit more complicated than just the black box that sometimes people think it is.
No, I love the way you explain it, and then all those intricate details, and the talking about formalin and the section in the slides, and then also floating it in the bath, and then
Yeah.
staining it.
And
Even
I forgot, I have a short video on my YouTube channel. I can either send a link to Dr. Wong, or you can just search my name, Jerad Gardner, and look up what happens to biopsy in the laboratory. And it's a short video that shows some basic steps, those steps I just talked about. If you're curious about like what actually happens when your skin sample goes to the lab, that'll show you kind of from start to finish how we do that process.
Yeah, I will definitely add that as a part of the sections of
Cool.
the video so people can get a much better visual sense of what the process. So bottom line is there's a lot of people involved in the process. That's what takes the time for the diagnosis to come back. But you also said this is not just like a machine reading it. There's
Right.
subjectivity, there's a human being behind it, a dermatopathologist, a pathologist.
Yeah, my brain is the machine. I'm looking at it through the microscope, and then I have to make a decision of what's going on, and if there's something abnormal there, and what the abnormality is, and if it's melanoma or something else. So yeah, it takes a lot of training to be able to do that. Obviously, you have to look at lots and lots of cases to be able to learn what's normal and what's not normal.
Yeah. And I think this is a very, very important point in my book when I was talking to people about the 5 steps when they first get diagnosed as melanoma. They really need to find out the accuracy of the pathology, right? And also who's reading it, the confidence behind this read. And it's not only, I think, it's accuracy, but the confidence of the people behind it. Can you comment a little bit about what does it take to become a dermatopathologist? What's the difference between pathologist and dermatopathologist?
Sure. So dermatopathology is the area that specializes in the microscopic diagnosis of skin disease. So whereas dermatologists look at the skin with the naked eye or maybe a dermatoscope, and they decide what's going on, and then they also treat the skin disease. So then dermatopathology is we look under the microscope at skin and figure out what's wrong with it. So 2 different types of dermatopathologists are all medical doctors, and you can become a dermatopathologist 2 different ways. You can either be a dermatologist by training or a pathologist. And both types of backgrounds are perfectly suited to becoming a dermatopathologist. So the steps to get there are you do your undergraduate college degree, your 4-year degree, then you go to medical school for 4 years to become a medical doctor. Then you do your residency, which is 4 years either in pathology training or in dermatology training. And then you finally go into a 1-year or sometimes 2 years, but most are 1-year fellowship program where you spend the whole year learning all about just diagnosing skin under the microscope. And so that's how you get to that level. So it's a lot of years of training and a lot of slides and samples that we look at to get there.
Yeah, that's how you, in your analogy of the machine, your brain is the machine. So more sample, more tissue you see, and the more experience you become. And I know that within dermatopathology, there are individuals who just specializes in melanocytic lesion, moles, and melanomas, basically.
Yeah, exactly. And in fact, I do a lot of different stuff. Most of my specialty areas in spindle cell tumors and other rare things. I see a lot of melanomas, but even I sometimes encounter cases where they're really complicated, and I show my colleagues, we do extra studies. Occasionally, we even send them out to the ultra world experts who focus very much on melanocytic pathology. So we work together a lot with other smart minds to try to figure out the more difficult cases. Again, most of them we can figure out pretty easily, but there are some that are really challenging and that we struggle with.
Yeah,
no matter
that is
how much training you have, there's always going to be some area where it's hard.
I totally agree, because I always say, like, biology is not black and white. It's
No,
very
we try to make things fit into the boxes and the books that we create, but the body is way more complicated than that. And it would be so much easier and more convenient for everybody involved, patients and physicians, if everything fit into a nice, neat box. But unfortunately, that is not how medical science works.
No, I'm so glad you brought this up. And I think this is also a very important point. That is, when I get a pathology report back, and sometimes there is a really value to be had about having a phone call with a dermatologist and a dermatopathologist and looking at the slide, looking at the clinical pictures or dermoscopic photos, and sort of come up with some sort of agreement, right? Because like you said, this is sometimes very challenging. That being said, I know that you got a whole bunch of slides ready for us. And this is really great because I think a lot of times I just want the general public to get exposed to sort of so what does a normal skin look like, first of all. And then let's look at perhaps a melanoma in situ, that's a stage 0 disease. And then we get to melanoma invasive. And what is, the most important thing is ulceration, is it breast cell thickness, and maybe you can even walk us through some of those fine details. Do
Sure.
you have any slides ready at this point?
I do. I can share my screen and show you.
All right, that's wonderful.
All right. Can you see that okay?
Yeah. So, all right, take it away.
All right, perfect. So what we've done here, these are were glass slides. This is exactly what I see under the microscope, but we actually have a special machine that's able to scan them and digitize them. And then we can pull them up to show them more easily and with a lot more clarity. So most of the time I don't use the computer to do my actual daily diagnosis, although some pathologists do, and we'll probably see more of that in the future. But I still use my trusty old regular microscope, but for teaching, it works really great to have a digital slide. So this is a piece of normal skin, relatively normal. I pulled from another case just for the sake of showing you. So let me show you the layers. First, let me orient you. You may think this looks nothing like what my skin looks like if I look down at my hand or my arm. And what we're seeing is actually imagine a little punch or a little plug cut out of the skin that takes all the layers. And then we're cutting it straight down from top to bottom. And like, that's what you're seeing, is you're seeing it from top to bottom. So up here is the very top layer, what would be on the surface. When you touch your skin and if you rub your skin, what you're rubbing is this layer right here, okay? That's the very top layer, the epidermis. And then down here underneath it, this pink layer is called the dermis, and it's the layer that kind of supports the epidermis and keeps the epidermis intact. The epidermis's job is to kind of keep everything else out of your body. It's a watertight barrier when it's functioning normally, and it keeps out germs and water and all sorts of chemicals, the elements, everything else around you. The dermis supports the epidermis, and then down below that is we have a layer of fat, this white layer at the bottom. That's called the subcutis. Or some people say the hypodermis, like you may have heard of a hypodermic needle. I usually call it subcutis, but some people call it hypodermis. But any case, that's the layer of fat that's down below. And then way down below that, we don't see it on this slide, would be like the skeletal muscle and then the bone if we were going all the way down. But here we're just going to focus on the skin today. So let's go in for a closer look. This is the epidermis up here, this purple layer, okay? And again, all of these cells, these are called keratinocytes, and their job is to hold on really tightly to each other and to keep the epidermis intact. So they're very strong. That's why if you rub your skin, it doesn't fall apart because they're all interconnected like a meshwork, with big cables of keratin protein running inside of them. You've probably heard about keratin. Keratin is the stuff that makes up the middle, the center contents of all these cells. These big purple dots in the middle are the nuclei. That's where the DNA is, and that controls all the functions of the cell. And then this pink, beautiful layer on top that looks like a little woven together basket. That's the top layer of the epidermis called the stratum corneum. That is made of keratin that's dead. Normally, it's supposed to be dead. That's the skin. Normally, the cells start down here, they grow up and go to the top, and then they undergo a program type of death that leaves behind this skeleton of keratin. And that's when you get flaky, dry skin and the dead skin flakes fall off. That's what's falling off, these loose bits of keratin up here. So this is normal. Now, you might wonder, where are the melanocytes? Well, the melanocytes are down in here. At first glance, you might notice these little brown cells at the bottom. Those are actually, surprisingly, not the melanocytes. They are cells that have melanin in them, but these are actually keratinocytes, the cells that make up the epidermis. The melanocytes are actually these little small, slightly darker cells in here. So melanocytes' job is to actually create melanin pigment, and that melanin is what gives our skin its color. It helps protect the skin from ultraviolet light to some extent. But the melanin is made by melanocytes, but is actually mostly stored in the neighboring keratinocytes. It makes like a little protective umbrella for them to keep over their nucleus to keep the solar rays out. So it's kind of cool, huh?
Yeah, it is very cool.
No nevus or melanoma here. This is just normal skin.
Can you show us the melanocytes again? I think the one important thing is this is a normal melanocyte. If you have melanoma, that is this type of cell that's actually sort of
Yeah, exactly.
Yep.
It's this little dark guy right here. I wish, unfortunately, I don't have this one. I can't zoom any further in on this, but that little dark round cell that doesn't look very special or specific at all. And their normal place that they live, so to speak, is along the bottom layer of the epidermis. So this is the epidermis, the bottom layer goes up and down here. And there's one of them every like 7 or 10 keratinocytes. There'll be most of the cells there are keratinocytes. And every once in a while, you have a single little melanocyte there, just hanging out down at the bottom. That's where they are supposed to stay, down at the bottom, right along that bottom layer. And their job is just to make that melanin pigment that gives the skin its color. So that's where they live. And then down below, you can see here, these are some small blood vessels, in case you're curious. This pink stuff here is collagen. You hear people talk about collagen a lot. It's one of the major proteins that forms the structural parts of our body, including the dermis. And then again, down below, we had some, oh, there's a hair follicle right there. These are sweat glands right here that make your sweat. And then down below, this is fat. This is what fat cells look like. And they look clear because all of the fat that's in them dissolves when we do those chemical bath steps of processing the tissue. All the fat dissolves and washes away and just leaves a little outline of their cells. So while we're here looking at skin, I thought those are things many people have heard of. There's a bigger blood vessel right here. And look, there's some red blood cells inside. Pretty cool, huh? It's never a boring job.
Very cool. So now we got a sense about what normal skin looks like. Should we flip over and switch to a slide showing melanoma in situ?
Yeah, let me show you one other thing first. There's one other skin abnormality that I want to show that is important for people to understand, because a lot of people have skin that have spent many years in the sun and have a lot of bad sun damage in their skin. And that creates a variety of problems. For one thing, a lot of melanomas, not all of them, but many melanomas are in some way related to ultraviolet radiation and sun damage, as are basal cell carcinomas and squamous cell carcinomas and a variety of other skin cancers. Also, the wrinkles that we see in the kind of leathery skin when, you know, you've had skin that's been exposed to sun for many years. All of that stuff comes into play when we are looking at skin that's been exposed to sun and we're looking for melanoma or other cancers. So I want to show you that you've seen normal skin now. This is abnormal skin, although I see this kind of skin so often that it's almost like a different type of normal. For older folks who have been out in the sun for many, many years, this is what their normal skin looks like oftentimes. See this gray blue stuff? This is not normal, right? I just showed you over here, the normal dermis is supposed to be nice, bright pink collagen. But what has happened is with many years of sun exposure, the collagen, it's still there a little bit, but it's been replaced by this thick layer of what we call solar elastosis. These are abnormal elastic fibers that have built up here and replaced the dermis, pushed that collagen down. The overlying epidermis is kind of thin. It's not very happy. So, you know, we all like to be out in the sun, but it is good to try to protect our skin from the sun as much as possible, because over many years, this kind of damage is not totally repairable. You can do some different things to try to make it a little better, but you're never going to totally take this away once you've gotten a lot of sun damage accumulated. This person was probably 70 or 80 years old and has had obviously lots of sun damage, but I just thought it was worth seeing that this is what chronic sun damage does to your skin. So when your dermatologist is telling you, you know, this will mess with your skin, they're not lying to you. I see the effects of it every single day in my job as a dermatopathologist.
I wish I had like a normal skin and a clinical photo of a normal skin of a young person and an elderly patient of solar elastosis look like that can match with your pathology.
We should get that together. You can like get a picture of each and I can get a path of each and we can make a little 2x2 panel to show, because I think that would be really valuable for people to visualize like what's happening both clinically under the microscope. Is more than just you got a sunburn. It's over the years, this stuff really adds up. And the results that we see, both you clinically and me on the pathology side, we see some really terrible things that happen from overexposure to sun, unfortunately.
Totally agree. All right, what's next?
All right, so let's look at a melanoma. All right. So here we had a biopsy. This was a shave biopsy. They've taken a little blade. The dermatologist has scooped out a little bit of skin and shaved it out. We cut it in half and then kind of embedded both of those halves on end and then sliced the slide here. So again, we're looking from top to bottom. And you can see that the one difference from the other skin is that we have these little round clusters of grayish cells in here. These are melanocytes, and they're clustered together into what we call a nest. Now, sometimes when melanocytes make nests, it's benign and they're just a benign nevus. I actually did not pull up an example of a benign nevus to show, but we do see that sometimes where we just have nests of benign looking melanocytes, and that's just a normal nevus. And there's a lot of different types of nevi, and it's actually kind of complicated, so it may be a little too much to go into in a video here.
Let's not do that. Let's just show the melanoma in situ.
Okay, cool. So this at first glance, I could look at and think, this could actually be a nevus. The cells are a little bit enlarged, but they're looking like they're in nests. But this was a case where I knew, because of all the training I've had and the many cases I've seen, that this looked a little bit like a nevus, but I was pretty sure that it was going to be something worse than a nevus. For one thing, one clue is I have a lot of that solar elastosis, that gray colored dermis down here. It's not as bad as the last case I showed you, but I could tell, even without any history, this person's older and has had some sun exposure, a good bit of sun exposure over time. And so what I did in this case is I looked at it, and I was pretty sure that there were going to be some findings in here that would tell me that we were dealing with a melanoma in the epidermis, what we call a melanoma in situ. So I did some stains to help me visualize the melanocytes better, that I could see that the cells were down here, but I thought there were some extra cells moving up towards the surface that were hiding in here and were a little difficult to see. So when that happens, we can use stains to help us make the melanocytes stand out with a different color and help us to visualize them better. So I'm going to show you that now. And here is an example of one of those stains. So this stain is called SOX10, SOX10. There's another stain that some dermatopathologists will use that's called MART1 or Melan A. It's a little different variation, but it does the same kind of thing. It's a stain that stains melanocytes. SOX10 also stains some other things like nerve cells and stuff. So it's a marker. It will stain normal melanocytes, benign nevus melanocytes, and also malignant melanoma melanocytes. So it doesn't tell me by itself if they're benign or malignant. It just helps me see the pattern. So I told you earlier that melanocytes normally, when in their normal state, they live along the bottom layer, and we don't like to see them moving up towards the top layer of skin, but that's exactly what they're doing here. All the red dots you see are the nuclei of melanocytes. And they're along the bottom, yes, but there's tons of them trickling all the way up to the very top layers of the skin. So that's what we call pagetoid spread or pagetoid scatter. And it's a pattern of growth in melanocytes that generally is not good. It generally is one of the clues towards malignancy. The problem is it's really complicated in deciding sometimes what's enough to make a melanocytic lesion malignant. There's not any one certain specific feature. It's a combination of all the patterns together, put together with the clinical situation, what kind of skin it is, if there's sun damage or not. Those things all together help us decide if it's melanoma. So that's goes back to part of how we were talking about at the beginning. It's kind of complicated. It's not a simple thing that you can just look at and say, oh, there's one cell at the top, it must be melanoma. So in this case, in the sun-damaged skin of an older person with numerous melanocytes trickling up there and scattering up towards the top of the skin, that's a bad sign. And then also, when I looked over here at the edges, let me see over here, I could see the melanocytes didn't stop. They kept going and trickling out. So this is a type of melanoma in situ that some people call lentigo maligna. And it's a type of melanoma in situ that usually occurs in chronically sun-damaged skin, often on the head and neck, the face, or the scalp of older adults. And it's called lentigo maligna because it can look kind of like, clinically to the naked eye, it can look a little bit like a benign lentigo, which are those brown sunspots that you see in older adults. But under the microscope, it looks different. So that's why dermatologists do biopsies, because sometimes it's hard to tell them apart for sure clinically. We have to look at it under the microscope. So the next question you might have is, what do we mean by in situ? Aren't all melanomas the same? Definitely not. There's a big difference, and the biggest difference is in, number one, is the melanoma confined to that top layer of skin, the epidermis? If it is, we call that in situ. In situ is the Latin word for meaning in the place where it originally started, basically. So normally, melanocytes live in the epidermis. So if a melanoma happens and stays in the epidermis, that means the melanoma is in situ. It's in the place where the melanocytes normally belong. They are still abnormal melanocytes, but they have not invaded down into the dermis. And the good thing about this is if you get, it's still something that needs to be removed and treated, but if it's removed completely, the chance of anything bad happening from this is very, very low, close to zero. There are some rare exceptions to that rule, but generally melanomas can only spread to other parts of the body or cause death if they are able to invade and get into the blood vessels or lymphatics and spread to other parts of the body. Melanoma in situ by itself, if you get it when it's still in situ and in the epidermis, it doesn't have that potential to spread to other parts of the body. So this was one that was totally in the epidermis. We couldn't see any invasion into the dermis. So this is melanoma in situ.
That's a great description about what the difference is between a atypical mole, melanoma in situ, and so basically this is a really important for the people who's listening. That is, when you get a pathology report and you want to look at for the word melanoma in situ, if you see the word in situ, the prognosis, the treatment is actually very, very good. The treatment is very easy.
Yeah.
And then just bring up this example. So this, you brought up the point that this is a lentigo maligna. It's a type of melanoma in situ, most of the time in a sun-exposed face, sun exposure like the face, an elderly individual. And this sometimes gets very tricky because sometimes surgical excision is obviously the standard approach, but sometimes it gets to be too big and you can't resect it. And so we have other options such as using imiquimod or Eldera, even though sometimes it's not FDA approved, but we have some good results, and some people even advocate for radiation, but we can talk about
that's a good point. That there, I did say it should be excised, and generally that's what happens, but there are some complicated exceptions, certainly, where it's not feasible to always remove the whole thing, but other treatments get used in those cases. And
why don't we
Dr. Wong there.
Why don't we shift gears a little bit, talk about what invasive melanoma look like?
Sure. Oh, and I did forget one other picture I wanted to show you here.
Sure.
That comes up sometimes is, what is PRAME? PRAME is a newer marker that's come out in the past, I don't know, 5 to maybe it's been 6 or 7 years now. And it's a marker that is often positive in melanoma cells and often negative in benign melanocytes or benign nevi. Now, no stain is perfect or 100%. That's one thing I've learned over many years of doing this, is stains are a useful tool that help pathologists, but stains are not like a magic marker that solve all of our problems. Unfortunately, it would be nice. We are always looking for the magic stain that will solve the problem perfectly of, is this cancer or not cancer? Not just in skin pathology, but in all areas of pathology. But unfortunately, most of the stains, there is nuance to it. But this stain can be helpful if we're kind of on the fence, if we're not sure if something's atypical, but we're not sure if it could be a really atypical mole, an atypical nevus, or if it's actually melanoma. Sometimes doing that SOX10 stain or MART1, like I just showed, can be helpful. Also doing PRAME can be helpful. So PRAME here, all of the brown nuclei are all the melanocytes, and most of the melanocytes, so pretty strong expression of PRAME in this case. So that's a pretty good sign that it's probably melanoma. Now, it's not perfect. There are times where nevus can express PRAME, and sometimes you can have melanomas that are negative for PRAME, but it can be a really helpful tool in certain situations. And so that's where it comes, the experience of being a dermatopathologist comes in handy, of knowing this is a time where this will really help or would not really be helpful. But I just thought I'd show that, since it's probably something that more and more patients will hear about or read about in their pathology report. And so when a melanoma is usually or oftentimes express PRAME in the majority of their cells, and that's uncommon, not impossible, but uncommon in benign nevi. All right.
Very helpful.
So now this is another case of melanoma, and we've taken that shave biopsy here. It's been cut into 3 pieces, and we're looking at those. And again, top epidermis layer, dermis layer, and then we don't actually see the fat layer here on a shave biopsy usually. So in this case, there is melanoma in situ. And I'll show you a stain in a minute to help you see it better. It's a little harder to see here. There's a lot of melanoma cells in here, but to the untrained eye, you may say there's just purple and pink. Don't worry. Even my medical students, a lot of times when they first start looking at pathology, they're like, it's all just purple and pink. I can't tell anything. It takes a lot of time and good teachers to help you make sense out of what we're seeing under the slide. But I promise you, there is melanoma in situ in here. But as I get over to this area, something changes. Now we have melanoma cells not just up in the epidermis, but now the melanoma cells are beginning to invade down into the dermis, past that bottom layer of the epidermis and into the dermis. And the problem with that is, in the dermis is where all the blood vessels and the lymphatic vessels are. The epidermis gets all of its nutrients from the dermis. All the blood vessels and lymphatic vessels are in the dermis. And those blood and lymphatic vessels, although they serve an important role for keeping our skin healthy, they have the unfortunate side effect that they connect to all the other parts of our body. And so when melanoma or other cancer cells get inside of those, they have the potential to be able to spread to lymph nodes or even to other distant parts of the body. So that's how that process, which we call metastasis, the spreading of a cancer from the place where it started to a different part of the body, like a lymph node or the lung or the brain or somewhere. That's how metastasis is able to happen. So that's why invasion is such an important thing that we look for in melanomas, because once there's invasion, then there's the potential that the melanoma could maybe spread to a different part of the body. So all the cells we're seeing here, these are all invasive melanoma cells. Well, almost all of them. These little tiny round cells here, those are actually lymphocytes. They're white blood cells, immune system cells that are here kind of trying to attack the cancer and fight against it. Unfortunately, they're not being totally successful here. But so these big cells here are the malignant melanocytes. So how do I know they're malignant? Well, one thing, I can look at the pattern in the epidermis and find similar features to what I showed you in the last case, that upward scatter or pagetoid spread. But here I have some extra clues to help me. In the dermis, I'm able to see some other things. These cells are very large, way, way bigger than normal melanocytes should be. And some of them are small and some are large. We call that pleomorphism. So when you have big cells and small cells, very big, dark nuclei, that's generally, those are some clues for the cells being what we call atypical, meaning abnormal in the way their cellular appearance looks. Also, we can see, it's not really probably totally clear here, maybe over here. Some of the nuclei have big dark dots in the middle. Those are called nucleoli. And big nucleoli are a feature that also tells us that maybe the melanocyte is somewhat abnormal. It's not a 100% marker of malignancy, but when I start seeing a lot of big nucleoli, that worries me a little bit. And the other thing that we see in this case, and not all melanomas have this, but they're mitotic activity or mitoses. This little purple thing that looks maybe like a little bird in the sky or a little caterpillar. Here's another one over here, this little purpley black squiggly line. That is a melanoma cell that's trying to divide into two and make new melanoma cells. So mitoses are the way that our cells in the body normally divide and make two. But generally, when we see a lot of mitoses in a melanocyte lesion, that's a worrisome feature that maybe we're dealing with a melanoma. Again, not 100%. There are times where benign nevus can have mitoses. But in this case, we do have several mitotic figures here. And when I see multiple mitoses in a melanoma, it's a sign that that melanoma is probably a rapidly growing one. And it's good that they got this out when they did. So
Jerad, let me interrupt you for a second, just for the interest of time. We have a few minutes left because one thing is there's a very important component called the breast lobe thickness. Can you tell us, like, I mean, it's from the top of the skin to measuring the deepest melanoma cells. How do you measure that?
Yeah, it's a great question.
For this particular example, where is the deepest melanoma cells and how do you measure it? Maybe you can walk us through that.
Yeah, let's see here. So in this case, yes, and that's what we do on every invasive melanoma. I measure a Breslow thickness. So you may see on your pathology report melanoma and a whole bunch of different little lines that talk about host response or regression or all these things. Of all of those things, the most important one in trying to predict how a melanoma might behave is the Breslow thickness. People have tried to figure out other ways over time, but so far the Breslow thickness seems to be the best thing that we have overall. Maybe that will change in the future, but for a long time now, Breslow thickness is the most important way that we can predict if a melanoma is more likely to be aggressive or not. And so for the Breslow thickness, what we do under the microscope, I actually have this little part right here. It's called the ocular. I have a separate one that has a little tiny measuring stick inside of it that shows me how big 1 millimeter is. And so I swap that out and look at the slide under the microscope. I don't have one here to show you, but I will tell you what we do is we start at the very top part, not the top of the flaky dead layer, but the part here with these purple little granules. We call this the granular layer of the epidermis. So I start at the top of the granular layer and I go down to the deepest invasive cell. So let's, for the sake here, there may have been one little deeper area here, but I'll show you this cell because this one's big and really atypical and it's easy to see. So that's what I do is I line up the top of my measuring stick here and I go down and I see how far down this cell is. So this melanoma, I looked it up, actually was a 0.8 millimeters in thickness from the top of the granular layer to the deepest invasive point. So the Breslow system, what it divides things into a T stage, and there's
Sure.
T1, T2, T3, and T4, right? And then sometimes we have an A and a B on those. So in this case, 0.8 would make this a T1B. And the T1 means it's less than 1 millimeter. And then it becomes a T1B if it's either 0.8 to 1 millimeters, or if it has an ulcer over the top. I don't have any ulcer to show you, but in this case, it was 0.8, so it was a T1B. And that's the area where the dermatologists and the surgeons start talking about, should we or should we not do a sentinel lymph node biopsy to see if the tumor has spread? Because once melanomas get beyond 0.8, they start having a higher risk of maybe spreading to lymph nodes. So then there's a discussion about whether that's the appropriate next step or not. And that's a pretty complicated topic, but I don't know if you want to delve into sentinel nodes or not here.
No, I think we got some other folks covering it. Jerad, thank you so much for this really, really helpful discussion and showing us all this illustration, melanoma in situ and invasive lesion. And again, we're kind of running out of time, and I'd love to have you back. And I see that you have a couple of other examples you like to show. But
sure.
I think we're running out of time, actually. But anyway, I just want to say
this is the main thing, honestly. So I just brought up more examples of the same kind of stuff to show. So, but I'm happy to come back anytime you'd like.
And I definitely will actually put Jerad, thank you so much for showing us all of those different variety of normal skin, sun damaged skin, melanoma in situ, and invasive melanoma. And this is a really, really great example in showing, all this mitosis and inflammation, and on top of which, you demonstrated exactly the process in measuring the Breslow thickness. It's really, really helpful, right on the fact that Breslow thickness measurement is the most important thing. Again, thank you so much for taking the time to chat with us. And I will definitely actually put some of the links that you have lots and lots of more examples on your own.
Yeah, I'll send you some stuff, sure.
Yeah, and I'm just gonna put it on there so people can look at it, and you really do a fantastic job in educating the dermatologist as well as the resident about how to do this. And again, I think the most important thing, I think the takeaway for our readers and the public is that this is not a black and white, and this is not something that it's a machine reading it. It's folks like you who have years and years of training experience and looking at thousands of those slides. And that is the most important thing. You want someone who's good in reading that slide.
Yeah, and just for the patients out there, just so you know, like every pathologist like me, we're behind here, and we treat each of these samples. They're not a piece of glass; they're a piece of a living, breathing patient. And I treat everyone like it's my grandmother or my wife or my kids or my brother. And that's the best gold standard I can give, is to take care of each patient like it's a member of my own family. So, you got a whole team of people behind you. We're rooting for you, and we want you to do well. We want to give you the best, most accurate diagnosis possible.
I could not have said any better than that. Thank you.
Thank you.